Medication Administration Part 5, Martha Olson from Iowa Lakes Community College. We have special considerations in many areas. We will talk about pediatrics, older adult, pregnancy, and the problem with swallowing or dysphagia. With the pediatric population, we know that many changes happen that can affect medication absorption, the decreased acidity in the stomach, and they have more body water, total body water, that affects distribution, less fat content, and their decreased protein binding ability for our medication metabolism. The blood-brain barrier is immature, so any of the medications that we give have the potential to get up into the brain and cause changes or damage. Smaller muscle mass helps us to know that we need to use that vastus lateralis muscle for our IMs and avoid the deltoid muscle. Pediatric factors continue to, the kidneys and liver are very immature for the first several months, and so the elimination of metabolism of medications might be altered as a result of organ immaturity. The urine pH is lower. The nervous system until about 8 months or older is not mature. We know that from checking the Babinski and the opposite reflex they have. Also, the ability for the child to have febrile seizures because of a high temp is also demonstrated with that immature nervous system. Excuse me, the vastus lateralis muscle is the typically biggest muscle that we want to use for our intramuscular, and our medication is given into the buccal area in a syringe without a needle. Pediatric tips then, it's usually safer to administer liquid that they can swallow down. Try to have that warm wet washcloth available because the liquid is very sugary and syrupy and sticky. Think about how you can easily distract that child. Try to give the injection quickly and allow choices if possible. Do you want it in your right leg or left leg? But don't ask them if they want their injection, because the answer is going to be no. So try to make it a positive question when you ask them. The EMLA cream numbs that area before you try to start the IV, and it should help make it more tolerable for them. And then be honest with kids, this will hurt. As we look at our dosage calculation, we know that typically the pediatric formula is milligrams per kilogram, and our older adult population has some considerations as well. Polypharmacy. Can we look at the meds and see, do they have to be on all of them? Are we giving them at the right time? Can we space them out throughout the day to help with decreasing drug interactions? And then decreased GI, drug and nutrient absorption. As the GI system slows down, we tend to see more constipation, but we also see possibly that they are taking more fiber in their diet to help decrease constipation. And we know fiber binds with the medications and alters or makes them inaccessible for absorption. And so are they eating a big bowl of bran fiber cereal in the morning and taking their meds, and that's why they're not working as well. So finding out all of that during a history and med history would be important. The decreased hydrochloric acid will alter the pH in the stomach, altering some of the medications that start the breakdown process in that stomach. As we look at water and fat content that tend to change throughout the lifespan, that can alter some of the medications for our older adults as well. The renal and kidney function need to be looked at, because we know as the nephrons become less effective in filtering and eliminating products through the kidneys, we can get a toxicity in the older adult. Look at their over-the-counter meds. Even though they don't think they're important, they can interact or impact other meds that they're taking, such as the Tums that causes meds to chelate and bind and be eliminated without getting to be used or metabolized. Can they fill their meds and afford them? Are they on a restricted or fixed income? Will Medicare pay for it? And so we think about asking them in a very tactful way about the affordability of their medications. Our geriatric questions also think about laboratory tests, our B1 and creatinine for the kidney. We think about our creatinine clearance, or looking at the ability of the kidneys to clear those out. For our renal function, and then the diet of the person again. Are they eating a lot of fiber and taking their meds? Are they taking their meds as they're supposed to? grapefruit juice, other things that can interact with the medication. As far as polypharmacy, we want to make sure that we are assessing for that and trying to lower the risk of any polypharmacy interactions or complications. As we look at our older adult in this question, the stomach's ability to produce hydrochloric acid might be altered, especially if they take a Tums or other GI medications that increase the acid and make it more of a neutral because they have maybe a GI bleed or other discomfort. When we look at pregnancy, we know that the fetus is particularly vulnerable, especially the first and last trimesters, and many women during that first trimester don't know they're pregnant, and that's when all those vital organs are being formed, and medications can cause a problem with teratogenic outcomes. Dysphagia, the ability to swallow or difficulty swallowing, we think about thickening the medication either with crushing and putting it in applesauce or pudding, thickening the liquids to help them to be able to swallow those, make sure they're sitting upright, have suction available at the bedside in case they start choking, and make sure that you have a full glass of water so if they would require more water to get that down. As we look at other vulnerable populations, we think of drugs that can be toxic, and maybe it's a person that's had part of their small bowel removed because they have Crohn's or colitis and they have difficulty with absorption that way. So many of our patients that take many medications fall into this vulnerable population that we talk about. Again, the pediatric patient, just because of the body surface area, difference in gastric pH and motility, and their total body water can alter the medications we give them. Older adults can be unpredictable. Are they remembering to take their meds? They have much more lean muscle mass that can affect the absorption and distribution of medications within the body. Are they eating? Are they malnourished? Is this an older adult that perhaps doesn't eat meat and has a very low albumin and protein level, which then we know that those medications would go unbound and circulation throughout the body would be affected. As far as decreased or diminished GI motility, those older adults with problems with constipation might have delayed absorption, and again, the kidneys and liver might be affected, delaying excretion of those meds. So we look at blood levels. We might need to reassess as you look at a patient that maybe they're starting on dialysis or the kidney disease is taking over and we're seeing decreased kidney function. Do we need to look at blood levels on a more regular basis for that person to make sure they're within a therapeutic level and not becoming toxic? Same with liver disease. As we look at some of our relatively fat-soluble compounds to more water-soluble compounds, which one is the older adult going to be able to eliminate and metabolize in a more effective way due to their changes in liver and kidney? Body size can be a consideration when we look at perhaps somebody that's overweight. We don't necessarily figure their medication on milligrams per kilogram because that would cause a toxicity. You're underweight, we might have to alter those med dosages as well because they do not have as much lean muscle mass or water and total body water. For our terminally ill, possibly a chronic alcoholic. And then your consideration for somebody that has an amputated limb, that will change their body size as well. Medications, some of them such as hydrochloric acid and liquid iron, can discolor the teeth to be a dark brown or black, so we need to think about how we can administer those to avoid staining the teeth. And then many of your oily drugs are better tolerated if they're cool. Our allergic reaction is a huge part of what we need to do. We give the meds safely. An unexpected reaction happens that we have to be on top of what we're doing to be able to react in an appropriate and quick way. We want to stop the medication if it's like an IV medication, like a sulfa or a penicillin that's hanging in an IV piggyback. Otherwise, medications that have been given IV push or PO are there. There's nothing we can do to get them back. Stay with the patient and get vitals. Protect the airway. Put the light on and get the supervisor coming with your anaphylactic kit or crash cart, and then have this doctor on the way, and they can do that from the desk as you're staying with the patient. Get the head of the bed up, get them on oxygen, keep assessing them. Is their tongue thick? Are they starting to slur their speech, or you have difficulty understanding their speech because of the swelling to the tongue and the airway? With that anaphylactic reaction, as it becomes more of an emergent situation, we give epinephrine as usually a standing protocol within hospitals or facilities. Again, keep assessing them, know what is in your anaphylactic tray and where it's kept so you can get to it very quickly. In the clinic where I worked and gave flu shots and also the allergy shots from the allergist in Sioux City, the anaphylactic tray had to be kept right where we administered the meds, and we also had to always have a doctor in the clinic at the time that those were being administered in case you got into trouble. Even though this clinic was attached on to the hospital, that was part of the protocol because of the high risk of anaphylactic reaction. Nursing diagnoses that go with this unit are listed here. Get in the habit of putting things in order as I look at these and which one is my highest. Even though it's a risk for injury, impaired swallowing, I would put that as my number one, simply because of the airway being a priority. This ends our unit on medication administration. I hope it's been helpful in your studies and in anticipation of the exam, and possibly questions you might have. Please let me know. Have a great day.